Can we start, or do we know if they're got a recorder going or whatever?
Yeah, they start us at 2 o'clock, so I think we have.
Got 2 minutes.
Yeah.
I just wanted to stand up so I could take this off.
Understand.
I know.
You still have one more day before it's official.
Yeah.
Oh, no, it's Stormont. It's all the time.
How's the news job?
It's good. It's good. I'm still balancing too. Tiffany starts next week, and so get her trained, and then I'll know more about my new job. At first, it was all COVID.
Yeah. Where's Dr. Teeter today?
I didn't hear back from him, so I'm not sure if he'll show up or not. Yeah, he's been very good at coming, so.
Okay. Well, it's 2 o'clock, July 7th, 2020, and we're ready for a presentation from Shawnee County Medical Society Health Access. Take it away.
Thank you, Commissioners. My name is Carla Hedquist. I'm the Executive Director of the Shawnee County Medical Society Health Access Program. And with me today, I have representatives from our Management Oversight Committee. First, I'll mention Kathy Smith, who is actually out of state but watching virtually from the Topeka Community Foundation. And then Krista Hahn, who is Executive Director of Marion Dental Clinic, Dr. Laurel Vogt with Cotton O'Neill, and then Denise Lance, who's with Kansas Medical Society and Shawnee County Medical Society. So I have some backup singers. Health Access just celebrated our 18th anniversary last March, and since 2002, we have improved access to health care for 15,762 low-income uninsured residents of Shawnee County. We're modeled after best practices in Buncombe County, North Carolina, and the model was brought here to Topeka by a group of physicians who belong to the Medical Society. There is a Project Access in Wichita that is similar to ours, and there's Wyjo Cares serving Wyandotte and Johnson County. So there are only 4 counties in Kansas that have this model of coordinated charity care. So I always tell our patients how lucky they are to live here, to have access to this kind of coordinated care. We combine donated physician care, hospital care, and prescription assistance to assist and help make our safety net more efficient. Our first goal is access to care. So first goal is preventative care. So every one of our patients, we make sure they have a primary care home. 73% of our patients go to Grace Med. 16% have private physicians such as Cotton O'Neill, University of Kansas family physicians, Washburn private physicians like Dr. Iliff, and then we also work closely with Vallejo Behavioral Health Care's primary care and Pine Ridge Family Health. So once enrolled in Health Access and they have a medical home or a primary care physician, then that physician can use our list of volunteers to refer to specialty care. And that's donated. We have over 300 physicians in both hospitals that donate specialty care, but they need that referral from their primary care home. But the critical piece is the prescriptions, because it doesn't do any good for the hospitals or the clinics or the physicians to donate care if people can't get their prescriptions and get well. So our job is to recruit the physicians and to make sure that they get only the number of referrals that they have said that they will see. So they tell us every year, I'll see 12 health access patients this year, or I'll see 24, or I'll see 46. And then that goes into our database, and so that's how we spread the charity care amongst them. We know how many cardiologists have agreed to donate and how many they've agreed to take. And so when the referral clerks are making their referrals, they try to use the next one on the list. So that's how the care gets spread around more equitably. And then we have over 300 physicians who are donating care right now. And then we check patient eligibility to make sure that they don't have access to any payment source. So they don't qualify for a medical card because they make too much. They're working. They don't qualify for Affordable Care Act subsidy because they don't make enough to get the subsidy. So they're the working folks working poor right in the middle that would be covered by Medicaid expansion if Kansas chose to do that. So it's much more efficient to provide that level of preventive care, medical home, specialty care, and keep them out of the more expensive emergency room and inpatient settings. 3 eligibility criteria: patients need to live here in Shawnee County, not have any other kind of health coverage, and make less than 150% of federal poverty guidelines. So that's $1,595 a month for a household of 1 right now. And so most of our folks are working. About 70% of our folks have jobs. I haven't run that report since COVID, and so I should run that again because I know a lot of people lost jobs. But they work, but they don't have jobs that offer health coverage. A lot of fast food, a lot of day labor, people who are doing landscaping and that kind of thing, seasonal kinds of work, and then hotel maids and that. So they're working really hard. They might be working 2 jobs, but they don't have jobs that offer health insurance. About 60% of our patients, 61% are female. A lot of single moms making decisions about their own health versus the needs of their kids. Only 16% of our patients own their own homes, and we have about 1,600 enrolled in health access at any given time. And 79% of our patients make less than 100% of federal poverty guidelines. So we really are serving the folks that need it the most, and we're proving that it works. Once individuals have access to a medical home, they have access to specialists, and they have the prescriptions that they need. When we do our satisfaction surveys and they've been enrolled for 6 months, they tell us 89%, which has been the percentage for each of the last 2 years, 89% are telling us that they have not been in the emergency department in the last 6 months. So we are proving that when you have access to the better levels of care, you don't need emergency room or inpatient. And so that's my favorite stat. We are seeing real steady referrals from the hospitals. We've had 356 hospital referrals this year to date. Last year we were at 359 at the same point in time, and that's just halfway through the year. Hospital emergency referrals, we see victims of domestic violence, victims of sex trafficking. We see individuals that have dental issues and are actually admitted inpatient, and we've had folks that need to be intubated because of oral health issues, people that are first-time diabetics or experiencing diabetic complications. We work with the homeless. And then, of course, COVID-19. We have individuals who are referred to us. So our response to COVID-19 is we're a very small staff. I'm the only full-time employee. We have 2 part-time staff, and we had 4 volunteers. But because we office at Stormont Vale, they didn't want the foot traffic of the volunteers in during the height of the pandemic, and so we lost our 4 volunteers. And 1 of them has returned now, so I'm pleased about that. We canceled our fundraiser, The Music Just What the Doctor Ordered, and so that was a hit to our budget. We went to paper applications only instead of doing face-to-face visits with patients to enroll them. Our part-time staff continued to work on site, both at the hospital and at Grace Med. They did accept crisis pay, which was a 10% cut for them and a 15% cut for me for 5 weeks, just to help preserve the budget during that time period. They are wearing masks at all times while they're working. We started accepting oral acknowledgments instead of patient signatures for the patients that were in isolation, because it wasn't prudent to have the social worker or the discharge staff go in and get signatures or to pass that paper around. And so they just witnessed the patient's agreement with everything that was on the application was true. We did see a slight decrease in enrollment during the pandemic, which is interesting, but I think because so many healthcare procedures were canceled during that time, that they were waiting to re-enroll until they can get back in and see their doctor again. And also, over the years, enrollment in health access has been directly correlated to the unemployment rate, and so I'm anxious to see if our enrollment increases dramatically over the next year because of that. Our administrative funding comes from the Topeka Community Foundation and the United Way. We continue to have good relationships with both hospitals. We are in donated space at Stormont and in donated space at Grace Med as well. We encourage all of our patients to visit the marketplace, and we work with the Grace Med Navigator to help people apply during open enrollment if they're eligible for marketplace enrollment during open enrollment. What we find is that as they're screening patients for Affordable Care Act, then they're finding individuals that don't qualify and referring them to health access at the same time. So we're kind of trading folks at that point. The need for health access really does continue. We are still seeing a lot of referrals coming from the hospitals. We're finding that patients are harder to keep engaged. We have a great opportunity now through funding through the Topeka Community Foundation, where we are able to provide some case management kind of services through Vallejo to actually go out into the community and work on social determinants of health, so a little bit more upstream than just provision of health care. So I'm excited to be part of that grant. But really, physicians believe that the prescriptions are one of the most critical parts of the program, and it encourages them to keep volunteering because they know if they diagnose someone with something as simple as an ear infection, but the person can't get their prescription, then their time has been for naught. If it's more serious, like hypertension, diabetes, then definitely the need for the prescriptions is very important. Another example is seizures. So we work really hard to maximize the prescription funding that we receive. We offer generics only. We don't do any over-the-counter medications like Nexium. We don't do prescription Tylenol. We never do narcotics or pain medications because of the potential for abuse. If they're a Grace Med patient and they have access to that 340B funding, then they need to use that first. And then what's not covered there, they can use their health access card for. We encourage them and help them to apply to the manufacturer for free and reduced price medications. Sometimes it's smarter to prescribe a name brand and get it from the manufacturer free than it is to use the generic and use the local funding to pay for it. All the pharmacies, we have 26 pharmacies in Topeka that are participating in our program, and they don't charge us a dispensing fee. They've also all agreed to MAC pricing, maximum allowable cost. And so if our patients go to any of our pharmacies, they're going to pay the same reduced price, discounted, that all those pharmacies have agreed to. And so we're blessed that we have the prescription network on board with us, and they're the ones who negotiate with the pharmacies on our behalf. Patients pay a $7.50 copay for prescriptions, so it's not completely donated. If it's on the $4 list, of course, they're just going to pay the $4. But anything over $7.50, we're going to cover. There's a $1,000 maximum per year, and so we're really encouraging them to use their money wisely, and if they're eligible for anything else, to use that first. We are seeing a patient utilization of prescription cards increase. In 2014, only 26.8% of our patients were using their prescription cards. First quarter of 2020, we've got 34.8%. And so I think people are seeing the need for prescriptions. We have a prescription subcommittee of our management oversight committee that scrutinizes our formula and makes decisions. We want the funding that we receive to last all year, but we don't want it to run out before the end of the year. And we want to serve as many patients with it as possible. So they make recommendations about any changes to the formula, and they bring that to the full committee of the Management Oversight Committee, which Commissioner Cook serves on.
It's the doctors, they have the technical background and training to be able to read all the meds and the pharmacies and it's way above my pay grade.
I have trouble taking notes. To go back and see how to spell some of the things. Also, our number of claims is increasing, and in the handouts, there's a prescription handout that I gave you. It's the one sitting on your desk.
Oh,
Yeah, I probably gave you one with the packet too, but this one will be more up to date. And it just shows the expenses to date. In all of 2018, we had 28,000 claims. 2019, we had 44,000 claims, and that was with similar funding. And so we are doing a good job of controlling the formulary and controlling the costs so that we can fill as many claims as possible. As of the end of June, and actually that report that you have is less 1 week, we'd had 33,000 claims so far this year. And our budget's doing really well. Again, we don't want to be over budget and we don't want to be under budget, and we are right on budget 6 months into this year. So I'm very pleased with that. Which is a good thing, because the physicians on our prescription subcommittee have told us that there's really not any more cuts that they feel like they can make at this time without actually hurting the health of our patients. So first of all, I want to thank you for the county's ongoing support. In 2014 and some years prior to that, we were receiving $122.5 from the county annually. And then in 2015 and 2016, I actually requested less. We only requested $100,000 because we had found some cost savings related to diabetic testing supplies, and we just didn't want to ask for more than we needed. So the last few years, 19 and 20, we've received $110,000 for prescriptions, which is what we're requesting again is level funding. Of that, $7,500 goes towards administration of the program, which is not quite 7%, and the rest goes to assist patients directly with the prescriptions that they need. We just got our score from the city. Our maximum funding level through the city is $50,000. We scored a 95% on our grant, and so we'll get 95% of our $50,000 request, so we'll get $47,500 for 2021 if that is approved by the full council. But that's what our score is recommending at this point. So why should the county invest in prescriptions for low-income uninsured? As you know, and you spend a lot of your time these days talking about it, but health is a community-wide issue. It impacts everyone's ability to work and pay taxes. 87% of our patients report that they're healthier and able to work because of health access. They help us take care of not only ourselves, but our property and our families. We shop, we pay taxes, and it helps keep people productive, which is what makes a vibrant community. Sick people, on the other hand, spread illness, and that negatively impacts productivity. Prescriptions can help people stay out of the emergency and the more expensive emergency room. And so that drives up the cost of health care for everyone. And then without prescriptions, sometimes people exhibit behaviors that could require assistance from emergency personnel, first responders, and that's a cost too. So the old saying that, prevention is worth a pound of cure really is worth it with prescriptions. And our community's strength, I think, lies in our ability to take care of those less fortunate. We don't receive any federal or state funding. We're a local program. We're a program of the local hospitals and the local physicians who are trying to make a difference. We don't, it's not, patients don't automatically get us. It's not an entitlement, but it's because the physicians are willing to donate it. Since the program began, we've had over $199 million in charity donated to assist over 15,000 individuals, and those are unduplicated over the 18 years of the program. We have a lot of people who may have been enrolled in 2002, come back in 2008, and show up again tomorrow. But we count them as one person in our database. So our patients aren't here to say thank you, but I brought a few of the survey responses because they're fun to read and good for you to hear. Health access is needed in order for me to live and to support myself. I need this service to obtain my medication at a lower price. Thank you to all the personnel that make this program possible. Without health access, I wouldn't be able to get all my prescriptions. Thank you very much to all the doctors for donating their time. I just had thyroid surgery, and I feel like my doctor saved my life. Thank you. You rock. I have so much gratitude for the medical care I have received. Without this, I wouldn't be able to get my meds or go to the doctors. Thank you. I'm thankful to Health Access because they help me with my prescriptions. This has been a good program for helping me with my mental health medicine and other medicines. I love my doctor and the care I'm able to receive. Thank you for your support. I've been seen by different specialty doctors and my health has improved a lot. I appreciate the program, otherwise I would have no medical care. This program is amazing. I'm finally able to see and get help for issues I've had for 5 years. Thank you so much. And these are just comments from the first 6 months of this year. So those patients aren't here to say thank you, but I am. And I greatly appreciate your support over the past years and hope that you'll look favorably upon prescription funding for the future. Happy to answer questions, or you can direct them to members of the Management Oversight Committee too.
Do most of the pharmacies in town participate in
Yes.
programs?
Yes,
Very good,
almost all of them,
very good.
yeah.
Commissioners, I've served on Health Access since the very beginning of my tenure as a commissioner, and I can say that of all the committee assignments, it is very rewarding to be on Health Access. There's a lot that they do that's in the community, just as Carla said, that it fills that gap. There are individuals that fall, and if there was ever a Medicaid expansion, they're the ones that would be picked up by it. But until that time, they're in that gap between, they earn too much, but not enough. And so providing the diabetic care, there's a lot that we put in early on into diabetes and treating that. But all the medicine, the pharmacies, the volunteered care from the doctors, there's a lot of the doctors that volunteer their time and money into this. And so it's just really a community collaborative. And so it's been a good return of investment.
I think we're a wonderful example of community collaboration. I've been with the program 14 years. The program's 18 years old, and I haven't seen this much community collaboration.
Very good. Very good.
Thank you.
Questions?
I would like to point out too that a lot of I've seen a lot of patients under Health Access when I was doing primary care. A lot of them are small business owners that can't afford insurance. They're trying to make their business work. Restaurant owners, construction company owners, painting contractors. So these are working people. They're not looking for a handout. They're working hard.
Very good. Very good service.
Thanks.
Okay.
Well, thank you for your time.
Thank
Thank
you,
you.
Carla.
Thank you.
All right.
Was our last one for today?
I think we have one more.
We do?
Yep.
I think there's a 2:30.
Yep.
Okay.
Thank you, Mindy. Thanks for your time.